There's a silent thief of vision affecting millions, and it starts with diabetes. Before you feel a symptom, your retina is already showing the truth. Dr. Craig Thomas reveals how modern eye imaging is catching damage early and saving sight.
Hello and welcome to the Dr. Kerry Gelb Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you enjoy our interviews, press like, subscribe, share, and hit the bell for updates on new episodes. Great news, our full-length documentary is now streaming on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. And visit my new website, wellness1280.com, for all guest links, resources, and past episodes. And I'd love to hear from you. Reach out to me anytime at drkerrygelb@gmail.com. So now please sit back and enjoy my conversation with return guest, Dr. Craig Thomas. Diabetes is now the leading cause of blindness in Americans under the age of 55. Even more alarming, 1 in 6 adults in the US, that's about 16% of us, are living with diabetes today. And the real crisis, only 7% of Americans are metabolically healthy, leaving a staggering 93% at risk for this potentially blinding and deadly disease. Today's guest, a return guest and a friend, Dr. Craig Thomas, an optometric physician based in Dallas, Texas. He has made his life's mission to change this, a nationally recognized educator, author, and lecturer. Dr. Thomas is passionate about early diagnosis of diabetic eye disease with a goal not just to preserve sight, but also to save lives. What if the earliest signs of diabetes could be seen years before the diagnosis, right inside the eye? In this episode, Dr. Thomas shares the tools, insights, and urgency behind the fight to prevent diabetic blindness before it's too late. Dr. Thomas, welcome to the Open Your Eyes podcast with Dr. Kerry Gelb.
Well, thank you, sir. It's always good to be close to you. I don't have a lot of optometrists I can hang out with where I still actually learn stuff, and you are in that small group. So I always like being close to you because we share information. It's not a one-way street. So
Well,
I'm glad to be here. Glad to be here.
well, I really appreciate that, and you've done great things over the years. In my opinion, that you're the best speaker, best eye doctor speaker out there that speaks to other eye doctors. Not only do you teach, but you're also very funny, very entertaining, and everybody's on the edge of their seat, waiting to what you're going to say next because you're really an unbelievable speaker.
Well, I got two things I want to say to start. I used to tell this joke. I'm getting old now, so it's been a while. But every once in a while, I would have a patient that would challenge me. My recommendations were that, almost like they didn't know what I didn't think I knew what I was talking about. So I tell them they'd have this condition or that condition, and they would say, "Well, are you sure?" And every once in a while, I'd have to just say, "Hey, I'm the optometrist of the year. I'm the best optometrist in Dallas, Texas. Don't you know where you're at?" And they would look at me like, kind of like I'm crazy, and then I wouldn't laugh. And I'm like, "I'm serious. I'm the best guy around here. You don't know how lucky you are." So I would always drop that on them when I needed to. And regarding the diabetes thing, man, my history with diabetes goes back. I was sitting here thinking while I was listening to your introduction. My first visceral experience with a person with diabetes, and I want to get that term out there, PWD, person with diabetes. Not diabetic. We don't use that word in my office. My first, intimate encounter with a person with diabetes was my godfather, and I was in college in optometry school. And he owned a cleaners down in Houston, Texas. He used to clean all my clothes for free, and I'd go hang out there. It was like hanging out at the barbershop, down at the cleaners. And he was, probably 65, 70 years old. I'm 19, 20, 21, hanging out at the cleaners with the guys, thinking I'm one of the guys. And it was fun until he got diabetes. And then lo and behold, next thing I know, I look up, he's in the hospital. And he spent the next 2 years in the hospital and never came out. And he had complication after complication, had 7 surgeries. They cut off his toes, cut off his foot, got the lower leg. It was like a shark attack. And I would always go see him after class in optometry school, and we would sit and talk. And I would like, this is the craziest thing in the world. I've never seen anything like this. But that molded me. It affected me, where I saw what diabetes can do to people. It could kill them. And if it doesn't kill them, it could cripple them. As eye doctors, we know it could blind them. But I've seen the whole spectrum, and after practicing for 40 years, now I've multiplied by 2,000. But that's where my beginning came from, is watching my godfather go through this debilitating end of life diabetes crisis, where he's going through these multiple amputations and essentially never coming out of the hospital after 2.5 years and passing away from diabetes, like lots of people do in this country. So that was my start. And then once I started practicing here in Dallas, I'm in an urban environment. A lot of people that are not rich, a lot of dark-skinned people, a lot of diabetes. On a regular day, man, I'll see 10, 12 people with diabetes, out of 35 or 40 people. I'm busy all the time. And so, I mean, it's every day. It's constant. And after 30, 40 years of seeing people with diabetes get sick, I'm getting kind of tired of it. And so I want to try to do something to stop it. Just like you. We got the similar history with the longevity. You've seen what this disease could do to people, and you don't like it, just like I don't like it. And we're trying to help. So I'm glad you let me in to try to help. That's my background on diabetes.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MySight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. One of the problems that I have, and I know we share this, is the guidelines. The guidelines are like 30 years old when it comes to eye care and diabetes. What has changed in eye care that allows the optometrist to be able to detect diabetes so early in the eye?
Well, there's the good question, and really that's one of the focal points of my lectures. I give lots of lectures on diabetes to optometrists, and I keep trying to modernize the staging system of the disease, because we still go by guidelines from 1989. With the early disease treatment, the diabetes study, and all they used, Carrie, was dilated ophthalmoscopy, whatever you could see with an ophthalmoscope. The term is I think dilated ophthalmoscopy observations. Okay, so that's the way it was in 1989, and they were studying. The guys that did the study, they were actually studying whether aspirin therapy or laser surgery was better treatment for diabetic retinopathy. I mean, when you think about the nonsense, it's almost like dinosaur years. They were actually doing a study on that, and they did the study. And they concluded that laser surgery was better than taking an aspirin, to try to help diabetic retinopathy. And that's when our staging system was developed, with all the no apparent diabetic retinopathy. That's the best thing I could say with the 25-year-old staging system, is that at least they recognized it says no apparent diabetic retinopathy, because they don't really know for sure when you're just looking at it. So the biggest thing, the answer to your question, the biggest thing that's changed, from just whipping out an ophthalmoscope and looking at the fundus, the retina, trying to see if there's some kind of vascular lesion going on. The biggest thing that changed, and it changed 10 years ago. You were one of the first guys that saw it change when you determined that multispectral imaging could diagnose early diabetes and early diabetic retinopathy and insulin resistance and metabolic syndrome. You figured that out 10 years ago. The technology didn't take hold, but we already saw 10 years ago that we could see stuff different than looking at it with an ophthalmoscope. So that was the first thing. And then the second biggest thing is OCTA, where regular eye doctors, not some fancy retina guy or lady, can actually see the vascular perfusion and performance of the retina, down to a capillary level. So once you could see really what's going on, from a vascular point of view, where ordinarily when I was in school and you were in school, we'd have to get some kind of fluorescein angiography. Well, now any regular eye doctor has the wherewithal to determine subclinical disease that's not visible with an ophthalmoscope. Okay, that's subclinical disease to me. And what we know now is that subclinical disease occurs way earlier than clinical disease, but it's just a continuum in the natural history. It's not some separate clinical entity. It's the same condition, diabetic retinopathy. We just have the technology now, OCTA primarily, again, from a structural point of view, to make the diagnosis of subclinical diabetic vasculopathy, to me, is the correct term, not retinopathy, because there's different kinds of diabetic retinopathy. And then once we started seeing, and I started seeing this, I mean, we've known each other 20 years. I was talking about this stuff 15 years ago because I started seeing it and I'm like, what am I looking at? And I would do OCT scans on people with no clinical diabetic retinopathy, no vascular lesions, but the retina is real thin. And I'm like, why is their retina real thin? And I'm trying to find what is this? Like, how come they only see it 2025 instead of 2020? So I started seeing this stuff a long time ago and started talking about it a long time ago because I saw the references. I wasn't the first or the second. I was the 18th guy that saw this. And the 17 guys before me all wrote articles. And I started seeing the articles talking about neurodegeneration. And so once you get your OCT, you can see the structural part of neurodegeneration. And then once you understand it, you can go into the functional aspects, looking beyond visual acuity to diagnose early functional vision loss. That's the difference. Is the technology is the OCT, OCTA that we didn't have 30 years ago. So you got technology there. Those lucky doctors that still have a functioning multispectral imaging can still use that. And then you go into the functional realm where you start doing all kind of electroretinograms, color vision testing, sensitive 10-2 visual field testing, objective field analysis, all kind of stuff to measure functional vision loss, because that is a clinical sign of diabetic retinopathy if you're going by the modern definition. And the modern definition came out in 2017 from the American Diabetes Association, talking about diabetic retinopathy as a neurovascular complication, past the vascular part where you go into the neuro part. And what I tell my patients, when I start, getting on my rant like I am now, is I like, hey man, if I see damage in your retina is part of your brain. Your brain's getting damaged. Okay, hey, we got to talk about this. This is getting serious. Okay, if I see any kind of retina damage, I just go one step further, and that kind of peaks that conversation real quick. So that's the on the technology, kind of a long answer, but that's the difference. Is we have the technology that's way different than it was 25, 30 years ago, and the scientific database and knowledge base to understand what we're looking at and see that the guidelines that we've been going by and still go by, because there's no general regulatory body that's going to change it yet. I don't know. We still go by these 25, 30-year-old guidelines, when if you really understand it, man, there's 5, 6 different levels of diabetic retinopathy that are not in the current staging system. When I gave a lecture one time a couple of years ago, I was joking, but I actually made up a slide where I was going to call it the Thomas grading system, and I had all kind of ischemic levels and levels that you can only see with an OCTA. And now on this presentation that you and I are looking at here recently, I've seen where just in the past year or two, this concept of functional diabetic retinopathy is now evolving, totally different from the vascular component and kind of parallel to a neurodegeneration component. Because to me, you got to have structural damage to produce the functional loss.
I
But
mean,
that's where we are.
guidelines to me are a problem because unless they're updated every year, the technology, like you said, has way outpaced the guidelines. And if we're training our students and the new doctors based on these guidelines, the technology is so much better. When I got out of school and we're using the ophthalmoscope and I would see a hemorrhage, typically the patient, and they had diabetes, the patient already knew they were diabetic. It's not like that anymore. Now we're the first doctors to say, you're at risk for diabetes. I see this hemorrhage. I see these microaneurysms. Yeah, and they're nowhere in these guidelines of these microaneurysms because we're seeing at 8 microns with technology. Back in the day, we were at 150 microns. So things have changed so much that we're able to pick up disease way before it's picked up by the internist.
Well, to me, we've got almost 4 levels of the disease that present. You've got the traditional diabetic retinopathy. To me, the correct term is clinical diabetic retinopathy, and it's all the stuff that we learned in optometry school, that ophthalmology residents learn. All the dot and blot hemorrhages, the microaneurysms that are visible with ophthalmoscopy, any kind of exudative formation, all that kind of stuff, any cotton wool spots, all the ermas, the stuff you can see with an ophthalmoscope. That's, to me, that is clinical diabetic retinopathy. And again, more accurately, it's clinical diabetic vasculopathy. That to me, that's the more accurate term. So you've got that whole thing there, okay? And they still teach that. And what I'm seeing, Carrie, is that if I even attempt to communicate with the primary care physician of my patients and tell them that my patient, that our mutual patient has subclinical diabetic retinopathy or has functional diabetic retinopathy, they almost look at me like I'm a quack. Like, what am I talking about? Do they have microaneurysms and dot and blot hemorrhages? Yes or no? Okay, period. Next question. And any attempt at going past that is met with some resistance, if not indifference. Certainly not inquisitiveness, where the doctor would call, hey, what do you think's going on? Their retina's real thin and their color vision's messed up. Do you think I should get more aggressive at treating the diabetes, or should we leave it alone? What do you think? Okay, I'm not getting that phone call yet. Are you?
Yeah, no, I mean, because they're still going by the 40-year-old guidelines. Now, when we look at the epidemiology of diabetes, it's increasing so much. It's almost 40 million people now, Americans, have diabetes. If you could talk a little bit about the epidemiology, about the increase risk and the increased amount of people getting diabetes.
Well, the numbers ticking up slowly. It was increasing rapidly over the past 5, 10, 15 years. And there's different parts of the country, different pockets where diabetes is much more common and prevalent than others. For example, it's much more common in Mississippi and West Virginia than it is in Massachusetts, if you understand what I'm saying. But generally speaking, we're approaching 11 to 12% of the population. So from an optometrist, ophthalmologist point of view, I mean, if I see 20 people a day, which is a slow day, two of them are going to have diabetes. I mean, that's just the way it is. If I see 40 people a day, four or five of them are going to have diabetes. If you're in an inner city urban environment like I am, 10 or 15 of them are going to have diabetes. So, you can pretend you're not seeing patients with diabetes. Okay, patients with diabetes are practically everywhere unless you're in some real fancy part of the country. So you got a lot of people. Uh, what I'm seeing in my practice, and again, I don't think I'm the average optometrist anymore because I'm 40 years in, so that makes me a little different. And just like I'm 65 now, I'm on Medicare. I'd say 70% of my patients are on Medicare now. They got old with me. We're all old together. Now I'm a good 65, but I'm 65. And what the stats show is that in a practice like mine, where the majority of the patients are older people, mature people. I'm not seeing kids. I'm not seeing young families. I'm in this urban environment, but I'm seeing 35, 40 people a day. And there's plenty of people that live here. It's just not young kids. Well, the stats show that almost 30% of people over 65 have diabetes. And so if you're looking to take care of diabetes, people with diabetes, to render the best care, to do the best doctor you can. If you're seeing a bunch of people over 65, 30% of them have diabetes. And what I'm encouraging, and I know what you're encouraging, is that we engage these people more than what we have perhaps done traditionally. Where we would have perhaps felt we were doing a good job if we dilated the eyes and looked in and didn't see any kind of vascular lesions, and we're patting them on the back and like, hey, good job, you're doing good with the diabetes. I don't see any complications. I'll see you next year. Good, keep it up, keep it up. You're doing great. But now, if I don't do an OCT and an OCTA and a visual field and a color vision, I don't know if that guy's got something wrong with him. Okay, him looking normal don't mean nothing to me because of what I know and because of the technology I have. So that the first thing you got to understand, if you're even close to being busy, a good number of people coming through your doors and sitting in the chair have diabetes. So make a decision. Do you want to kind of fluff it off, or do you want to get into it and try to do the best you can? And again, we're encouraging trying to do the best you can, and part of that is knowing about it, like we're talking about here. So you got to know, if you're seeing a bunch of people on Medicare, and I know lots of eye doctors that do, 30% of them have diabetes. Okay, that's a target-rich environment. And then the second part of it on the epidemiology thing is people with pre-diabetes. They walking around getting ready to blow up. They something's wrong with them. They haven't met the numbers yet. It's like back in the old days. All these old ladies would come in. They say, "Is my cataract ripe yet? Is it ripe? Is it ready for surgery?" And like, "No, ma'am, it ain't ready yet. It got to soften up a little bit more." So with all these people with pre-diabetes, they getting ready to get diabetes. They just one cupcake away. That's all it is. They right there. And if you got the technology, like multispectral imaging or OCTA or even like even an ERG, you could see that it's getting ready to happen. And again, what I'm thinking now, it's already happened. We're just using old numbers. If I see somebody with a 6.3 A1C and I see OCTA abnormalities and enlargement of the foveal avascular zone and microaneurysms that you can only see on that guy's got diabetes. Okay, okay,
Yeah, because pre-diabetes isn't pre anything. I mean, you're at risk of,
it ain't, there you go. It ain't pre anything. It's the same disease.
and, and one of the things that's important for the public to know, they might have these changes in the back of their eye, but they don't feel any pain.
Oh yeah.
It's everything is good until it's not good
No,
anymore.
I mean, Carrie, I almost feel guilty about the years that I practiced where I felt like I was doing a good job, above and beyond almost, dilating asymptomatic patients with 2015 vision and no complaints just because they had diabetes. Because that was standard of care. We're going by the guidelines. I never saw anything. And it'd almost be like I'm a 7-year-old kid on the soccer field and everybody gets a participation trophy. Hey, everything looks good. You did good. Like I'm taking credit for it. Like I'll come back next year.
Right, it looks
Just
good until it
ridiculous.
doesn't. And these are arbitrary numbers. 5.7 to 6.4 is pre-diabetes because a bunch of smart people a number of years ago sat in a room and they came up, these are the numbers, but they didn't have the technology that we're using
Exactly. It's
today.
it's all it's all fluff. It's
Those numbers should be much, much lower. And the whole concept of insulin resistance and being the cause of diabetes and high blood sugar being the symptom, that brings me to risk factors, modifiable factors, risk factors, non-modifiable factors. Why don't you go into that a little bit?
well, that's I still like being an optometrist where I could talk to my patients. I still, if I want to spend 15 minutes, kind of shooting the bull and chit chatting and talking about the kids, I could do it. If there's 6 people waiting on me, I done got old enough to where I don't care. So talking to people is something that historically optometrists have been able to do more than the primary care doctor, especially in the current environment, and certainly more than any kind of retina specialist and most general ophthalmologists based on my experience. And I went and I hung out with one of my patients 2 months ago to go have a cataract consult with the general ophthalmologist. I hadn't done it in a long time, and I just wanted to see what the encounter was like. And it was okay, but I'm better. Unless you're getting ready to get cut on, you're going to get a better experience in my office, and that's just the way it is because I'm good at it. And one of the things I'm good at is going through modifiable risk factors with the patient versus non-modifiable risk factors. And we talk about it. I've learned this from you a little bit. I mean, I've done my own study, but every time we have an all docs meeting, I see what's on the menu because I know you got your hand in it. It's going to be some kale and fresh rhubarb and berries up in there somewhere. Ain't gonna be no red meat and prosciutto. It's going. So you understand it. I see that. So the modifiable risk factors factors, you always start with diet and exercise. You hate to be trifling and just go with, where everybody has gone before. If you got some person with diabetes and, it's a 50-year-old lady and she weighed 280 pounds. I mean, she knows she's big. I don't have to tell her that. And if she could lose weight easy, she'd have lost it. She'd already done it. So I'm real smooth with it as going into that conversation. I did it 2 or 3 times today. I had one girl in here this morning, my first patient, and I took fundus photos. I walked in, and as soon as I walked in, because we were joking around, just laughing because I hadn't seen her in a year. And then, they took the fundus photos. We put them on the big screen. I went and started my next patient, came back in. As soon as I walked in on the big 40-inch flat screen, you got these crystal clear clarus fundus images showing all this tortuosity of the vessels. And I'm like, hey, is your blood pressure acting up? And she bowed her head like she stole my dog. And she said, yeah, they've been working on it. I'm on a new medicine right now. I'm like, well, you better get to it. I mean, so I do that. Okay. I started, so we spent 6 minutes talking about blood pressure. Okay. So we talk about diet, we talk about exercise. I talk about my most common question is I ask people what they had for breakfast. That gets it going, and you could go 10, 12 minutes if you got time with that as an open-ended question. If I have time, and I make time, because I could do a refraction in 2 minutes, with all the help I got. So I'll spend my time doing this, and I'll talk to them about standard breakfasts and what I had for breakfast and how I lost 30 pounds and had to hire a trainer to figure out how to lose weight properly and do it nice and slow, and we'll get a plan. The guy went through all of that stuff this morning with that lady. I did. So we talk about exercise, we talk about diet, we talk about what you had for breakfast. If you've got any existing vascular disease like blood pressure, we talk about how it might turn into glaucoma. If you got diabetes, we talk about how it might turn into glaucoma. We talk about things you can do, the modifiable risk factors, if they actually have diabetic retinopathy in a vascular sense. Then I talk about supplements. And there's a couple of supplements out where there's enough scientific data that shows you have a strengthening of the blood vessel walls, a kind of a reduction in vascular leakage. So there's some benefit in some people. It's like taking macular degeneration vitamins. It don't help everybody, but 35%, it'll slow it down. And if you're in that group, then it's good for you. So I talk about supplements if I see early vasculopathy, microaneurysms, and I'll try to add supplements to the diet if I don't think they're getting enough antioxidants, green leafy vegetables, orange fruits. I'm real heavy on the cantaloupe, heavy on the spinach. I go heavy with that, and then go supplement. So I talk about those modifiable risk factors, and then I break into my comedy road when I go into the non-modifiable. If when you non-modifiables, if I got a black lady or a Hispanic lady, if I got a lady that I see her whole family and everybody weighs 300 pounds, okay, if everybody in the family got diabetes, starting with the grandmother, I've been here 40 years, I done seen all of them, every one of them got diabetes, every one of them. Okay, well, they can't change that. Okay, so those are non-modifiable risk factors, and so we talk about them, and I say, look, I can't change, I can't change that you 60-year-old black lady weighed 200 pounds. Okay, I can't change that, but this other stuff we can work on. Okay, so we talk about modifiable, non-modifiable, and it could be a white lady. The lady I'm talking about this morning, she was a white lady, and I told her, I said, look, you're a big girl. And she laughed. I said, look, I ain't laughing. You're a big girl. Okay. You about 150 overweight. Okay. You strong. And she laughed. She was big, she was carrying it, but she probably 5'5", maybe 280. Okay. And she's coming in to get some bifocal contacts, trying to be cute. So it was
By the way,
hilarious.
what did she have for breakfast?
She had some coffee because I asked her. She had a cup of coffee. I got so mad. I went and got a protein shake out the fridge. I said, drink this now. And she's like, I don't want it. I said, drink it. I'm gonna make you drink it. I'm gonna make you drink it in front of me, like taking castor oil. So I keep protein shakes in the fridge, man. You got to help them.
America's greatest fear is blindness. It's not cancer, it's blindness.
Oh, when I talked to her about the blood pressure, she snapped to attention. She got straight as an arrow there for a minute. She was taking notes. So I discuss those, and again, I'm fortunate enough to where I'm in my own business, I own my own practice, I can do whatever I want. Now all my patients love me. It's like a cult. If they wait an hour to see me, they don't care. I got, I got a lot of flexibility, and you have to have some flexibility to do this properly. I used to try to schedule return visits to do it. And I did that a little bit, but it don't make no sense in real life. Where I'd examine the person, do an eye exam, and I say, okay, I want you to come back in 2 weeks and we're going to talk about diet and exercise, but I really wouldn't examine them. I'm just talking to them. And I'm like, nah, this is lame, and I really couldn't bill for it, because I'm not doing anything. So I do it. So I try to get it in while they're in. And sometimes if especially if they've got dry eye or some other condition, where I'll have a return visit within a week or two or three, I'll just kind of have it go on, and pick it up the next visit. But if I need to, I will take 10 minutes and go through this as required throughout the day. I think it's that important.
It's interesting with obesity because about 25% of adults who are obese are diabetic. That means 75% are at risk or are not diabetic yet. But even thin people, 12% are diabetic because we have the skinny fat people. If you may want to comment about skinny fat people, where they're fat on the inside, but not necessarily on the outside.
Well, that's the ones I see with the fatty liver disease sometimes,
Right.
out of nowhere. And I'm like, what? What are you talking about? Uh, that's a subgroup. I'd say maybe 10%, like you said, just off the top of my head. So they certainly exist. So being thin or of normal physique is no guarantee of health. The guarantee of health is to make sure you're healthy. By doing a thorough modern exam and running a bunch of tests on you. That's how you make sure you're healthy. It's important to look good, but it's more important to be good. And that's how you determine if someone's good or not, is you do all the stuff that we're talking about. You dilate their eyes, you look in the retina, you see if there's any obvious vasculopathy. You go into a subclinical mode and you do OCT scans, you do OCTA scans if you have that technology. And then you go past that and you go functional, because you could still be semi-normal OCT and OCTA and have functional deficits. There's no rules. You can have decreased retinal sensitivity, abnormal color vision, a decreased electroretinogram waveform in the presence of 20/20 vision and no vascular lesions. You don't know until you look. You got to prove they're normal. You can't hope it. That's the difference.
And the technology is so amazing. We're going to get into that in a little bit, but let's talk about refractive changes. People come in for eyeglasses, contact lenses, and it's very interesting what diabetes does to people's prescription and how they see. If you could talk a little bit about that.
Well, there's six things really that happen to people's eyeballs when they get diabetes if they're going to have complications. So, and I always, I don't know, we want to be doom and gloom with all my patients. I always, try to be upbeat and positive unless I see something wrong with them. And I'll always start the conversation. Hey, you can have diabetes for 40 years and nothing could happen to you. And I got plenty of patients just like that because I've been practicing 40 years, so I can say it for real. Hey, I've seen people with diabetes for 40 years and there's nothing wrong with them. Okay, that's possible. Maybe 30%, 40%. But that means 50% don't. Okay. So you got a whole group of people where you're going to have some kind of complication. Now, I won't say embarrassed, but I remember when I was in optometry school in 1979, they taught us basically two things from what I can remember in the olden days, is that people could get these refractive changes, like what you just mentioned, where you go from Plano to +3 in 2 days, and the person comes in like, hey, I can't see, and I was seeing last week. So they said I remember, Care, that was a big deal, man. They hopped on that was like 4 days worth of lecture talking about osmotic changes in the lens and swelling and deswelling. I went all into the physiology of it because I lecture on this stuff. I reviewed those articles. I'm like, okay, there's stuff going on, all this osmotic gradient stuff and all that kind of thing going on, changing the shape and size of the lens. And so that's what they taught us in optometry school. And then of course they taught the basic vascular lesions of dot and blot hemorrhages, microaneurysms, all the stuff you would see with an ophthalmoscope. And if you got real fancy, you would send them to a retina specialist to do a fluorescein angiogram. Okay, that's all I remember. I don't remember nothing else. There was zero about diabetic keratopathy, zero. Well, I take this back. There was a tiny, tiny bit on the diabetic snowflake cataract that I think I've seen twice in 41 years. Okay, I think they spent a day on that. There was no talk about glaucoma because nobody had glaucoma back then. We're doing the NCT pressures, getting the whiplash pressure, so nobody was getting glaucoma. No diabetic keratopathy, no corneal desensitization, nerve damage, neuron, none of that. There was none of that. So either you went from +0 to +3 or from +3 to +6, or you had a bunch of bleeding in your eye, and that was it. Okay, that's what they taught us. Now, what I got to tell you, Kerry, is that in my 41 years of practice, and man, if there's a new machine, I buy it the day it gets out. I mean, I got a space shuttle for the machines in my office.
Sure.
Okay, I for every person that I've seen with diabetes where they come in with the complaint of, hey, I was seeing fine last week, but now I can't see anything. And they get a +2 or 3 diopter shift because they got some 800 blood sugar that's out of control that they didn't know about. And it's changing their whole body physiology and fluid balance, and they're getting ready to have a coma. Okay. I can, in 40 years, man, I could count those guys on 2 hands. I think I had one this year, and that was probably the first one in a year or two. It is not common. Now, I'm an established guy. Most of my patients are established. It takes 2 months to get an appointment to see me. I hardly see any new patients because they can't get in. They go someplace else. So I might not be seeing a representative sample, but I talk to optometrists all the time, and I'm telling you, I don't hear this a whole lot. What I do see almost all day long is retinal neurodegeneration and subclinical diabetic retinopathy that I'll pick up with my OCT and OCT. I see that like 10 times a day. Okay.
You know what?
So as far as changes, if any eye doctors are wondering how do I, get earlier on the train, it ain't waiting for the guy to turn into a +3 when he was a plano. That you can wait on that if you want to. It's all this other stuff is going to be like 100 times more often than that. That's what I've seen.
It's interesting. When I was in school, they taught us that when your blood sugar went up, you became more myopic, and it's the opposite. And for all the students out there, I don't know if they're teaching you that. They're still teaching you to become more myopic when your blood sugar goes up, but you become more hyperopic, just like you said.
Yeah, it is. It is interesting why there's a disconnect in the formal education and clinical practice sometimes. But there is definitely a lag on this topic. And it's not just in schools, it's in residency programs, it's in insurance companies, it's everything. It's in ICD-10. ICD-10 doesn't recognize this. Not yet. No, they don't.
Now, you talked about a corneal problem. Let's talk about that for a minute. Stuff that was never talked about years ago. It's things we see now. People, they're more likely to get dry eye. They have trouble if they get an abrasion. They won't heal as quickly. Talk to us a little bit about that, the cornea, the front part of the eye. And we spend a lot of time talking about the vascular part, and that's very exciting, but it also affects the front of the eye.
Well, the biggest thing is so you've got this condition called diabetic keratopathy, keratopathy meaning corneal damage, of course, and the primary mechanism is nerve damage. And that's one of the when I talk to my patients about how does diabetes hurt you? How does diabetes mess you up? Well, I always start off, do you have that tingling in your fingers and toes? And if you ask 10 people with diabetes that question, you go get yes 4, 5, 6 times. And so if they say yes, to that hey, yeah, I get that tingling in my fingers and toes, I got to tell you, it's on. I'm getting ready to go crazy. I'm getting ready to run every test. I'm getting ready to ask every question. I'm gonna look in every corner because that's a clinical symptom of nerve damage, peripheral nerve damage. And I tell my patients, I spend 3 minutes on it, and I'll say, look, you got your central nervous system, you got your peripheral nervous system. Central is the brain and spinal cord, peripheral is all the other ones. The further away from the brain they get, the smaller and thinner and more fragile they get. That's why the fingertips and the toes get messed up first because they're so thin and fragile and far away from the brain. I go through all of that. Okay. And I say, if you got peripheral neuropathy, nerve damage in your fingers and toes, it started in your brain. Okay, it didn't start in your toes and work up to your brain. It started in your brain and worked down to your toes. So if you got peripheral nerve damage, you got central nerve damage. Okay. Central nerve damage is the retina. Retina is part of the brain. And now it's all making sense. Okay. And so now I'm connecting the dots with the patients because I'm getting ready to say, look, you might have this, you might have that. This might be messed up. We got to run this test. I got to look over here. This might be going on. For your cornea, you know what I just got? I got me one of them aesthesiometers.
Hmm.
Yeah, yeah. There's two kinds. I got the Cochet. You
Uh-huh.
get one for about $800. Man, I want to get that Brill. Have you seen that one?
No.
Oh, it's slick.
And what are you finding? What are you finding when you're doing it?
Well, you measure corneal sensitivity.
And what have you found by measuring corneal
Well,
diabetic significantly?
oh yeah, you definitely have decreased sensitivity because you got nerve damage. And again, the way we're made, the eyes, practically the most sensitive part of the body because it's so fragile. Okay, so once you lose the sensation where you can't really tell if your eye's getting messed up or not, well, your eye's going to get messed up. So once you start losing, sensation, all kind of bad stuff starts happening. So the same neuropathy that gets the toes and the fingers, the same neuropathy that affects the retina, and we measure with OCT scans as decreased retinal thickness and atrophic processes. The same thing we measure with functional vision loss affects the corneal innervation too. And so you lose the neural biofeedback, the what's the correct term? The lacrimal functional unit.
Right,
So the
right,
lacrimal functional unit is disrupted when you have abnormal innervation. Well, the abnormal innervation is from diabetes. Well, okay, that's why the eyes start to get dry. Okay, and the abnormal innervation goes to the meibomian gland. So now you have decreased meibomian gland function. Everything goes down. Okay, so the aqueous production goes down, the meibum production goes down, the corneal sensitivity goes down, everything goes down. Okay, well, you got three things going down, it's going to go down. Okay, the person's going to have problems. They're going to have clinical signs of abnormality, they're going to have clinical symptoms of ocular discomfort. So that's your diabetic keratopathy. And so now part of my workup in a patient with diabetes, I don't wait for them to say my eyes bothering me. Because again, if they have decreased sensitization, they're not going to complain. So you got to measure it. So you measure it with the little cord that comes out of the machine, and if they have decreased sensitivity, then that's just one more piece of the puzzle where I'm like, okay, this diabetes is messing with you. Do you want to get healthier? Yes or no? Let me help you get healthier. Let's talk about diet. Let's talk about exercise. Let's talk about nutritional supplements. Let's talk about whatever I could talk about. And I got to tell you, I don't hardly ever involve the primary care physician. I don't pick up the phone. I send them the little lame reports that we got to send them because if they was going to do it, they would have already done it. If they was going to have this conversation with them, they'd have had it. And what because you had the same conversations throughout your career, is when I sit down and go face to face with somebody for 12 minutes, talk about diabetes, what I hear like 18 times out of 20 is nobody ever talked to me like this before. Nobody ever mentioned this stuff before. How come nobody told me this already? How come nobody told me what I'm supposed to be doing? What's going on here? That's what I hear.
I had
Okay.
the thing. I want to ask you how far in the disease do you start seeing decrease in corneal sensitivity? Is it an early sign, a
No, it's
medium
late. It's late.
sign?
Yeah.
It's very fascinating what you just talked about. How about cataracts? Cataracts.
Cataracts, they taught us about the diabetic cataract, which if you look in the literature is this snowflake design thing. Again, I think I've seen three of those in 41 years. Okay. That's not what happens. It's just standard cortical clouding, spoking, the loss of transparency. It just happens earlier. That's because the person's not as healthy as they could be. So if I had to just pick a number off the top of my head, they would start to get, and when I say they, people with diabetes would start to get clinically significant cataract formation 5, 10 years before people without diabetes. So you get them earlier. That's
I
what
always
I've
look
seen.
at diabetics, they're aging quicker. It's a sign of aging quicker, and they're getting aging diseases quicker, just like cataracts, about, like you said, about 10 years earlier than a non-diabetic. How about glaucoma? Talk to me about
Glaucoma, I got it, man.
metabolic syndrome.
Glaucoma is the thing. Okay. If you talk about an association with diabetes and diabetic retinopathy. Now, again, I think I have a slightly skewed practice, slightly, because I've got a lot of Black patients, a lot of Hispanic patients, real high incidence of glaucoma, just period. And then when you fuse in diabetes and high blood pressure, just the numbers go off the chart. Just like in a regular day for me, 30 patients, 10 of them are going to have diabetes, 10 of them are going to have glaucoma. That's every single day. And half of them, they got both. Okay, so I see an extremely high correlation between people with diabetes and people with glaucoma. And what I explain to my patients, and they, again, I have these conversations all day because again, most of my patients are established, without sounding, trifling, I could do a refraction in 30 seconds, on somebody I've seen 20 times. Which is better, one or two? Okay, we're done. So I don't spend a lot of time messing around with that stuff. People come to talk to me. That's what in my practice now, people come to talk to me. And what I describe, excuse me, because I've seen it, I'm just describing my own personal experience, is in my practice, again, I'm mature, most of my patients are mature. People turn 45 or 50, they get high blood pressure. They turn 5 years later, they get diabetes. 5 years after that, they get glaucoma. And so it's all this sequence of vascular diseases, excuse me. And as I explained to them, these are all vascular diseases. And I go real basic because everybody understands it, where I talk about regulatory mechanisms. If it's a guy, without me sounding sexist or chauvinist, I talk about a car and a car thermostat. When I was a kid in high school, I remember my thermostat stuck and my car overheated. And I learned about thermostats when I was 16 years old. Everybody's got a house. I talked to them about the thermostat on the wall, setting the temperature. You set your thermostat at 72 degrees. If you want it colder, you move the thermostat. So I explained the thermostat concept, a regulatory concept. The thermostat regulates stuff. If it's diabetes, we got something in our body that regulates the blood sugar, some sensor, some biofeedback thing, something in there. It knows what we're supposed to be, and if we're not, then it does something about it. Secretes more insulin, does something. So we got some sensor that maintains stability, whether it's blood sugar, blood pressure, eye pressure. I go there. So I said, we got all these vascular things that all have to be regulated, just like the temperature in your house, the temperature in your car. I said, when people get diabetes, the thing that regulates the blood sugar, it's broke. It broke. Something happened. When people get high blood pressure, the thing that regulates the blood pressure, it broke. Okay, something happened to it. It just broke. Okay, people get stuff. People get glaucoma. The thing that regulates the eye pressure, it broke. And these things are all related, like dominoes falling. So if you got one regulatory mechanism that breaks down, it's real easy to have an associated or second regulatory mechanism breakdown, or even a third one down the road. So I explain how the association between diabetes, glaucoma, high blood pressure all exist almost like a continuum. It's not one disease, but they are connected. And so I said, look, hey, we got to watch out for this. So that's how I go into my diabetes glaucoma connection, as I explain what vascular disease is and how the body regulates different type of vascular components. And when those regulatory mechanisms break down, we call it a disease.
And it's a good point, and we're going to get into it in more detail a little bit about neurodegeneration. But glaucoma is a neurodegeneration disease.
Absolutely. It absolutely. I said when we met, I talked about glaucoma being a neurodegenerative disease because you had abnormal VEPs in people with glaucoma. So now you're down at the level of the lateral geniculate nucleus. Okay, it's not an eye disease; it's a brain disease that affects the eye. That's what's going on. If you just look at the science.
Now, going back to vasculopathy or bleeding in the eye, or changes in the blood vessels in the eye, what percentage of people with diabetes will start to get bleeding in the eye?
It's a lot. Depends on how long you've had diabetes primarily. So the again, and we're generalizing, just kind of, most people, most of the time, there's no rules. Everybody's can be different. Everybody's
And a
unique.
lot of times we
But
don't know how long somebody's had the disease.
yeah. And I tell people when I was in school, they taught us that 2, 3, 4 years, the person might have diabetes before they were diagnosed. Then you fast forward 20 years. I remember reading some article where it said the average was now 6 years. I don't know what do you think now?
Yeah, I think if they get their eyes examined, it's going to be shorter because we're going to pick it up sooner at the optometrist's office, way before they're going to pick it up at the internist's office because of the changes in the back of the eye. But probably the average person's had it about 4 or 5 years before they're initially diagnosed.
I agree, and I like I say I'm the majority of the time I have this conversation. I tie out 6 years. That's what I tell them. I said I ask them, when did you get diagnosed? When did you start taking medicine? If they say last year, I say okay, you've had diabetes 7 years. So we
Right.
go at it like that. Okay. And again, as far as those numbers, again, I said early on, you could have diabetes 35, 40 years and have absolutely no complications and live a long, healthy life and nothing wrong with you. But, you got lots of people with lots of problems. And as you stated, diabetes and diabetic retinopathy is the number one cause of blindness in younger working age population. And what the stats show is that, after about 10, 15 years, about 23, 25% of the people are going to have visible retinopathy, clinical retinopathy. See, that's the only numbers we got now. There's no number. I spent several months reading this summer. There's no articles talking about percentages of diabetes induced retinal neurodegeneration. We don't know. The only thing we've been kind of studying is the traditional clinical vasculopathy. I see your eye bleeding, and I almost, again, kind of in a comical mode. I'm talking to my patients. I walk in, I look at the fundus photos, and I'll start off the conversation. I'll go, well, your eye's not bleeding. It's like people say, hey, how's your kid doing? I go, well, he's not in jail. He's all right. So I go, yeah, your eye's not bleeding. You might be okay. So that's the first group, is that first group of people we see where they're that first 10 years. I think you're going to have 25% of those people easy, with some kind of retinopathy. And then once you go past that, it could be 40, 50, 60%. Once you got people with 20, 25-year runs, and I'm privileged enough to see that because I've been practicing for 41 years in essentially one location where I've seen the 40-year-old person turn into the 80-year-old person a bunch of times. So I'm seeing it now, not just reading it. So the longer you have it, the more likely it is. And a good point here, because I'm almost embarrassed. I spent years, I mean years, maybe 20 of my 40 years talking nonsense, okay? Well, just diabetic nonsense. Because I would always tell people, for the first 20 years of my career, that if their blood sugar was under control, if they were doing good, that they had absolutely nothing to worry about. And that good control of your disease would essentially insulate you and protect you from going blind. All you had to do was do the right thing. Okay, that was so stupid. Okay, because it's not true. Okay, what we know now is that there's no level of blood glucose control that protects you from developing diabetic retinopathy. Zero, none. There's no level. Okay, it's just the luck of the draw. It's time. It's three or four moving parts, but there's no safety valve where my blood sugar is fine. I'm fine. Okay, good for you. Okay, let me check you out. Okay, there's no level that protects you. None.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight one day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.